there was an interesting article written in the Journal of Hand Surgery in about 2017 by, there's a guy named Jinbo Tang, who's a Chinese hand surgeon, and they came up with a protocol for treating zone 2 flexor tendon injuries, and he basically, this guy's like a master surgeon essentially, and he said, well, this is how I do it in terms of how many strands repairs, how bulky is my knot, how open, how much will I bend the pulley system, and this is how I do it. And then he gave this protocol to all different surgeons all over China, and they basically said, okay, this is how I do it, and then he looked at everyone else's repairs and using the same protocol, and he said, well, this is how they do it, sort of their interpretation of what his protocol was, and they looked at all their results across the board, which were somewhat similar. So basically, and the take-home message is that you can vent the pulley about 2 to 2.5 centimeters. So he's sort of flying in the face of our traditional dogma that you need to preserve A2 and A4 completely, and basically saying that you should try to preserve them as much as possible, but you can vent the pulley system a certain amount in order to improve the excursion of the tendon and still get a good result. And then don't be afraid of making a bulky knot, because the worst thing you can have is basically a poor knot that doesn't hold things together, and that shouldn't be as concerned about maintaining certain anatomic landmarks of the pulley system. And so, in a personal note, I've come to realize or think of tendon repair more as management of pulleys instead of less of management of the tendon, because I think we've gotten pretty good at technically putting 2 ends of the tendon together, but I think we're not so great at determining how to manage the pulleys, because I think the problems occur with the interface between the tendon and the pulley is really where the problems occur, and not at the actual interface of the tendon anastomosis itself. So that's my own personal feeling. All right, anyway, so to move on. This is my talk, so I'll talk a little bit about me. This is where I'm talking about tendinopathy of the forearm and wrist. Just a little bit about me. I went to medical school at Case Western in Cleveland. I'm originally from Ohio. I did my plastic surgery training at Mount Sinai in the city, and then did a fellowship in hand microsurgery at UCLA. I have no financial disclosures. So I'm going to talk a little bit, just give a general overview of forearm tendinopathy, talk about pathophysiology, some just general treatment strategies, and then some common conditions that we see in our practices regularly. So taken in total, the tendon disorders are probably one of the most common causes of an office visit for an elective hand surgery office visit. Just for example, you can see the trigger fingers are about 2-3% of the population, and up to 20% of patients in diabetics. And despite this being a common entity, the literature is surprisingly sparse. And I think that's a theme we'll see across a lot of this. They really haven't advanced the care of this much in the last 50 years. The treatment is really driven more by history and anecdote than true outcomes-driven data. So, pathophysiology, just a funny cartoon I found. So, it's been called tenosynovitis, tendinitis, tendovaginitis. These are all referred to as the same entities, but the truth of the matter is this is all inaccurate. Even though we describe it this way, this is really not what's going on. And the most consistent finding across the board in all of these conditions is actually absence of inflammation. It's not an inflammatory process, it's a degenerative process. And so we see myxoid degeneration and not inflammation. So they've done pathologic studies, and there's a complete absence of inflammatory cells in these. But what we do see is that there is a pathologic interaction between the tendon and the tendon sheath. And so you get chondroid metaplasia, you get actually vascular invasioning, fibrosis, and thickening of the pulley, and this mechanical interaction between the pulley and the tendon is what causes the nodularity and the fraying and the impingement of the tendon. So actually it's really more of a pathologic process of the pulley than a pathologic process of the tendon, which is not really the way we traditionally think about it or traditionally describe it. Again, they don't see any acute inflammatory cells on pathology, and just in general, the histology of other tendon disorders is just not well studied or not well understood. Maybe because it's not a sexy topic, or because there's not a lot of commercial viability to the topic, but it's not something we have a lot of information about. And then if there is inflammation, is this primary or secondary? Is this inflammation a secondary process or a primary process? But it is clear that garden variety tendinopathy is not the same entity as a true inflammatory tendinitis that one would see in, say, a rheumatoid patient or mycobacterium infection or gout or pseudo-gout. They are definitely a different entity. So what are our treatment options? And these are pretty much the same across the board for most of these conditions. There's either non-surgical and surgical management. Our non-surgical management is again fairly similar across most things. There's activity modification, essentially avoiding what the problematic actions are. So if it hurts, don't do it. It's pretty simple. Therapy, which actually has been shown to help. Splinting, so strategic splinting, and steroid injections. And in terms of surgery, you have a tendon compartment release that's going to be done. That's been described in a million different ways: open release, percutaneous release, endoscopic release. Essentially, the ultimate goals are the same. And I should talk a little bit about steroid injections, corticosteroid injections. This is really a mainstay of non-surgical treatment, but if we think about what I just told you 2 slides ago, this is not an inflammatory process, so why does this work? And it's an interesting question, because we all do it, but and for lots of different things, but and the question is, why does it work? Does it block are we blocking the inflammatory response from occurring? So are we blocking a secondary inflammatory response? Maybe. It probably does control some interaction between the tendon and the surrounding tissue, resulting in decreased adhesions, decreased collagen formation, and also has been shown to block nociceptive signals. So the steroid actually blocks some pain receptors, pain signaling, within the wound itself. But the reality is the results you can't argue with results. So the results are generally good, meaning that about 50% of patients in most studies get long-term relief with a single injection. A second injection will capture about another 25%. So these are average numbers, with an additional 2 or 3 injections. So we'll say 3/4 of the people come in, you give them some injections, and it solves their problem. But just back to what I mentioned before, are we solving their problem, or is this just regression to the mean? Think about that. And it's less effective in diabetics. So again, to add more strength to the fact that this is not an inflammatory process, someone did a trial in 2017 where they compared injecting a steroid to injecting Toradol, which is an intravenous NSAID, into the wound, and the Toradol didn't help at all. So it's certainly not a controlling inflammation issue, that's not the mainstay of action of the steroids. But we have a lot of questions, again, because the literature is fairly sparse. Now, what are the long-term results of this? We don't really know. I mean, a lot of the studies cut off at about 2 years follow-up, so the long-term results are not really well known or well studied. If someone needs more than 1 injection, what's the optimal timing? I think it's pretty clear that at about somewhere between 2 and 4 weeks, if the patient has not responded, then maybe a second injection would be indicated, but when is the best time to do that? Nobody really knows. Certainly there's anecdotal protocols. I mean, I do it about every 6 weeks, but I can't tell you why, unfortunately. What's the maximum number of injections that people can have? Nobody knows that either. It's sort of like you give them as many until you have a complication, is essentially what it is, but that's not very scientific. Usually there has been, in terms of cost-effective treatments, that has been well studied, and the protocol seems to be that 2 injections and then surgery is the most cost-effective way of treating most of these conditions. Specifically, that was looked at in trigger fingers. So that essentially is what I do. Is usually 2 injections and surgery. I'll give a 3rd injection if it's a patient that has some underlying reason why surgery is not advantageous for one reason or another, comorbidities, timing, whatever it is. Sometimes they come in begging you for a 3rd one, but generally I try to stick to 2 injections and surgery overall. And then there's a difference in steroids. There's lots of different formulations. There's soluble, non-soluble, short-acting, long-acting. There's some benefits to different types of formulations. Most people use either methylprednisolone or triamcinolone are the most commonly used. But there are complications: fat atrophy, thinning of the skin, hypopigmentation, and then tendon rupture. So the first 3 are fairly common. Tendon rupture with steroid injections is fairly rare. I would say require multiple injections over time to even get that, but it is something that you think about. And then I threw up this slide just not because it's related exactly to what we're talking about today, but because it's related directly to steroid injections in general. This is a study that I did looking at the effectiveness of steroid injections for lateral epicondylitis. And what you see on the graph is that the patients that had steroid injections got better immediately, so much better 3 and 6 month results. And this is comparing steroid injections to either doing nothing or having therapy. And so at 3 and 6 months, steroids did much better. At a year, they were all the same. And going further, the people that had steroid injections actually fared worse than the patients that had either nothing or therapy. So did the steroids prolong the duration of the problem, or is this just regression to the mean? It's just more food for thought. That's why there is no universal agreement as to how to treat a lot of these things. Just a quick anatomy lesson. These are your 6 dorsal extensor compartments. I think most people are familiar with this, but it's starting from the radial side to the ulnar side. And the first entity I'll talk about is Daquaries Disease. I thought it'd be appropriate to call it a disease. This is probably the most well-studied entity outside of trigger fingers. The incidence is approximately somewhere 2.8 per every 1,000 person years for women. It's much more common in women than men, about 5 to 6 times. There was an epidemiologic study looked, and they found that the most common risk factors are female gender, age, so age greater than 40, and African Americans for some reason. It's common in pregnancy, but this condition is usually self-limiting in pregnancy. Who was Daquaries? Well, he was a Swiss surgeon. He was an authority on thyroid disease. He described lots of things, including the use of iodized salts to prevent goiters, as well as Daquaries thyroiditis, and also Daquaries disease, which we're talking about today, which also is called a washerwoman's sprain. What are the symptoms? There's radial side wrist pain and swelling. It can radiate. Oftentimes I find the patients present and they say, well, I have pain with certain activities, or I have pain when I'm doing this or that. But patients can oftentimes localize or vocalize exactly what bothers them or what they're doing. It tends to be a twisting combination, opening jars, opening doors, cleaning, those kinds of things, which is, I guess, why they call it a washerwoman's sprain. You can have a catching or a snapping sensation, and these patients can be in severe pain. It's not necessarily mild. I mean, some people come in miserable and debilitated from Daquaries. It's not a joke. And it can be possibly related to repetitive motion, although that's not very well worked out. And you have to differentiate the diagnosis between other issues that can cause radial-sided thumb and wrist pain, specifically CMC osteoarthritis, STT arthritis, that's scaphotrapezial trapezoid arthritis, thumb triggers and intersection syndrome, and these entities can be occurring concurrently, so it's not necessarily occurring in isolation. So another interesting fact about these things, what we usually test is called most people will refer to the Finklestein's test, which is actually really the Eichhoff test. So what Finklestein originally described is the examiner sitting across the table, grasping the patient's thumb, and then ulnarly deviating the wrist. But what most people describe as the Finklestein test is grasping the thumb into the palm, and either the patient ulnarly deviating or the examiner ulnarly deviating the wrist, which is really the Eichhoff test. But which is interesting is that Finklestein actually was the first one to write down the Eichhoff test, or record the Eichhoff test in a paper, which is why probably we all call it the Finklestein test. Anyways, another confirmatory test is you can have the patient fully flex their wrist and abduct the thumb against resistance, and this will more isolate the APL and can cause also painful symptoms. But remember that this can be very painful for the patient, so you have to be a little bit ginger when examining them sometimes because they can hate you when they're done. So again, for the anatomy, it's the first dorsal extensor compartment is what we're talking about. It contains the abductor pollicis longus and extensor pollicis brevis tendons. A couple things, the APL can have multiple slips, so it's not just one tendon running through there. Sometimes it can have 3 and 4 slips. It can have multiple strands, and then oftentimes there is a subcompartment within this which contains the extensor pollicis brevis. And this is much more commonly present in patients that have Daquaries versus the general population. So about 70% of patients with Daquaries have this subcompartment versus 20% in a general anatomical examination. And again, we see thickening of the edema of the retinaculum, which causes the friction, and it's again not inflammatory. And same slide for the treatment options as we had before, but the prognosis is very good. Again, 50 to 75% short improvement with steroid injections, As steroids have been shown to be superior to splinting alone. Splinting tends to help you at the moment you're wearing it, but as soon as you take it off, it starts to bother you again. And there has been no splinting has not been shown to have any benefit after an injection, so don't do it. But there are studies that suggest, as again, the concept of regression to the mean, that it's a self-limiting condition. They did a population-based study that about 50% of patients a year or two later had no symptoms. So is it there with the patients, they come in when they're in severe pain, if we did nothing and examine them again at some time interval later, would their pain just be getting better naturally? Nobody really knows. I mean, when you see someone come in in severe pain, our impulse is to treat them, and so we do. And so it's hard to say what's really going on here. But the prognosis is good. And certainly the prognosis with surgery is excellent. I mean, some studies show near 100% long-term success with surgical intervention for Daquaries veins. So it's not something I'm afraid to operate on at all. So again, the indications for surgery is failed non-surgical management. You can make a transverse or longitudinal incision over the radial styloid. I favor a transverse incision. You protect the branches of the radial sensory nerve. It's generally described to release the retinaculum, kind of as you can see on this slide here. On the bottom, on this dorsal aspect to prevent subluxation of the tendons volarly. That's not generally an issue. Some people have described flaps of retinaculum to prevent the subluxation of the tendons, and it's very important to examine for the subcompartment. So you have to make sure you see the subcompartment. If it's there, release it. That is one cause of failure. Complications, probably the worst complication you can have is an injury to the radial sensory nerve branch. Paresthesias can happen after surgery. True injury is probably pretty rare, but it can be devastating. The recurrence can be due to a failure, again, of the subcompartment release. Volar tendon subluxation, although it's not that common. Some people will splint for a short period afterwards of surgery to prevent this or counteract it. And CRPS, also not common. Intersection syndrome. So this is different than Daquaries veins. It was first described in 1841, but it was named intersection syndrome by Dobbins, who was a hand surgeon from the Mayo Clinic. It's basically localized pain and swelling in an area which is about 4 to 5 centimeters proximal to the dorsal wrist crease. So you can see in the little cartoon that's there where the primary pain area for Daquaries veins is versus intersection syndrome. So it's tended to be a little more dorsal, a little more proximal, and it's really at the area where the outrigger tendons or the APL, APB, EPL, where they cross the common wrist extensors, which is where the name intersection syndrome came from. And oftentimes you'll describe what's called a wet leather crepitus, or footsteps in fallen snow, kind of feeling as the patient moves their thumb. They can feel this sort of crepitation occurring right at that area. And you can compare the swelling to the opposite side, and typically it's a more gradual onset of pain, as you would see in Daquaries veins. But the real pathology going on here is a problem with the second compartment. So it's not actually the friction of the two muscle bellies that are crossing each other, because that makes no sense at all. It's really a problem of the second compartment. And what you're seeing is that the synovium, or the inflammation that is occurring, is pouching out proximally because the second compartment is so tight. It's not allowing the symptoms to be visualized there. So when you treat it, you're actually treating the second compartment and not actually the area of inflammation. So initial treatments are NSAIDs, rest splinting, and if you're going to inject somebody, you inject them in the second compartment, not necessarily directly over the area of swelling. And the surgical management of it is decompression of the second compartment. Surgery is rarely required, but the studies have shown that it's, although limited, that it's very successful. Another entity which is worthy of mentioning, which is a little more complicated, is Extensor carpi ulnaris tendinitis. There's a spectrum of problems with ulnar sided wrist pain, which could be a whole talk in and of itself, but ECU tendinitis is certainly high on the list. Just a quick talk about anatomy there. The extensor carpi ulnaris tendon muscle belly, it originates from the middle third of your ulna and the lateral humeral epicondyle, and it inserts in the base of your fifth metacarpal. This is what runs in the sixth compartment. So your sixth retinacular compartment, if you can see from the little cartoon, the blue structure is the retinaculum, the red structure is the subsheath, which is really a more important anatomic structure. It's a tight fibrosseous tunnel that covers the groove in the ulna where the ECU tendon runs. It's about 1.5 to 2 centimeters long. It's a soft tissue sling. And what is important is that in pronation, the tendon has a fairly straight course from its origin to its insertion. And supination, because of the radial translation of the tendon, it's got an angled course. And this is what can result in instability. So if you have the most unstable position is supination, ulnar deviation, and flexion. So if you have somebody you're concerned they may be subluxating their tendon, you want to examine them with their forearm in supination and an ulnar deviation, and you should feel that tendon pop out. And that's how you would examine them. This does require some injury to the subsheath, but it's complicated because some degree of hypermobility of the ECU is actually physiologic. So about half the people will normally subluxate a little bit. So is it, with what they're seeing, pathologic or physiologic? Sometimes it's hard to tell. But if you have true instability where the tendon is popping out of the groove in the ulnar head, this is a problem. And again, this occurs with injuries in forced supination and ulnar deviation and flexion, such as racket sports, golf, weightlifting. I've seen it a lot of times in patients that use like industrial drills, where the drill snaps back and their wrist twist. You can see it there. And it's been described in everything as a classification system, so you can essentially rupture on the ulnar side of the sheath, the radial side of the sheath, or you can get this false pouch which occurs as the subsheath itself strips off the periosteum, but it remains in continuity. And again, the treatment's pretty much the same. Rest NSAIDs to start. If you're going to splint somebody, these generally require a long arm splint. So you put someone in a long arm splint, and you want to splint them sort of in the opposite position of instability. So instead of if supination and ulnar deviation are unstable, you want to splint them in the opposite way, which would be pronation and radial deviation. You can splint them in pronation and radial deviation for a while. These things tend, I think, to linger and take longer to heal than we give them credit for. So I'll do sometimes 4 weeks or longer in a splint to see if somebody that's for a true dislocation. If they're only subluxating, you can probably treat them in a short arm splint and sort of activity modification for a shorter period of time. And then there's a million different ways described to repair this. Either direct repair, using a graft, you can deepen the ulnar groove and reattach it, and those are just some cartoon versions of it. But it's common, and it's very common in athletes. This mechanical degeneration can result in tearing of the tendon, which is an MRI finding that's pretty common, but doesn't really have a lot of significance. It's usually kind of an insidious onset, and it's usually a clinical diagnosis. I don't think MRI is necessary in any way, but patients will often have them from other providers. And there's something called the Ecu Synergic Test, where you have somebody rest their elbow on the table, supinate their forearm, and then you as the examiner sit across from them, and you ask them to abduct their thumb while holding their middle finger, and that will synergistically have them fire their ECU, and they should have pain. And that's another test, physical exam that's described, finding that's described. Next is the fourth compartment, tendinitis. So this is a rare entity in a non-rheumatoid population, but you see it. You can see it in trauma, such as a non-displaced distal radius fracture. Usually it's a non-surgical treatment, and then if it's really bad, you would do a tenosynovectomy surgically. You can see triggering of the tendons, which are mostly in the index and middle fingers because of the angle leaving the retinaculum. But a little more commonly, you can see a ganglion cyst from a dorsal wrist that's kind of woven its way through the fourth compartment. People have multiple extensor slips, and there is an entity, anatomic entity known as the Extensor Digitorum Brevis Manus, which is a kind of an accessory muscle that occurs in about 2 to 3% of patients. And you can see that this is a cadaver model and a real life version of it. And this sort of extra structure within the sheath can cause what looks like swelling in the fourth compartment. FCR tendinitis, also common in patients with golfers and racket sports. The FCR has this thick sheath that runs from the musculotendinous junction all the way to the trapezium. It has a very tight fibroosseous tunnel as it runs through the trapezium body. And we come across this when you're doing trapeziectomies for arthritis. the pain, you see pain with resisted flexion and radial deviation. It happens in patients with scaphoid fractures, distal radius fractures, underlying arthritis. Even when you treat it, so it can be a problem associated with some of the surgical treatment for, if you use the FCR tendon or part of the tendon for CMC arthritis. And then finally, calcific peritendinitis, excuse me. It's another cause of common wrist pain that occurs. There's only a minority of patients will have a history of trauma, but it's sort of the sudden onset of swelling inflammation, most commonly at or near the FCU insertion on the ulnar wrist. And why this happens is you have a deposition of calcium in the peritendinous tissues. A lot of times you'll see this sort of fluffy calcifications that occur in or around the TFCC area on your x-ray, and this is really diagnostic, but you can sometimes the calcifications don't come out until after the inflammation has started, and so it's important to rule out infection in this case. The treatment here is NSAID, the steroid injections, so you better be damn sure that there's no infection, but you want to inject and treat these with steroid injections. And that's it.